Hello all, hope you're having a great day today. So today we're talking, it's chapter 20, part 3, and looking at comorbidities and exercise. So here we go. So diabetes mellitus is a metabolic disorder stemming from abnormal pancreatic insulin production and or diminished peripheral action of insulin. Diabetes is positively associated with the development of multiple diseases and disorders of the heart, the vascular system, such as stroke and hypertension, kidneys, eyes, and nervous system. Diabetes seriously compromises the heart and vascular system such that it is listed as the 7th leading cause of death in the United States. CVD mortality rates are up to 4 times higher in those individuals with diabetes mellitus compared with those without the disease. Looking at current data, it is clear that diabetes continues to be a significant problem in the United States. To date, 29.1 million American adults, 9% of the U.S. adult population, have diabetes mellitus. Of that total, 21.1 million are diagnosed cases, with 8.1 million undiagnosed cases for people 20 years and older reported in 2014. 2 categories are used to classify individuals with diabetes, type 1 and type 2. Type 1 diabetes typically results from an autoimmune response, whereby the body's own immune system mistakenly destroys the insulin-producing cells in the pancreas. Type 1 diabetes compromises approximately 5 to 10% of all diagnosed cases of diabetes. This leaves 90 to 95% of all diagnosed adults in the category of type 2 diabetes. In general, the critical risk factors for type 2 diabetes are associated with a sedentary lifestyle. Primary risk factors for type 2 diabetes are age, family history, ethnicity, obesity, high alcohol intake, high fat diet, high blood triglycerides, high blood pressure, and gestational diabetes, or giving birth to a baby weight more than 9 pounds. The most recent statistics indicate that 25.8% of individuals 65 years and older have diabetes, with a rate of new cases reported increasing across the lifespan. Moreover, it is estimated that approximately 81 million adult Americans have prediabetes, 36.8% of the U.S. adult population, a condition in which blood glucose values are elevated beyond normal values. Fasting blood glucose of 100 to 126 milligrams per deciliter is considered to be normal. These individuals have a markedly increased risk of developing type 2 diabetes in their lifetime. Although type 2 diabetes is more commonly associated with adults, it is now on the rise in children, fueled largely by inactivity and poor diets that lead to obesity. Therefore, fitness professionals should recognize that diabetes prevention is appropriate for all populations, not only for the obese, but also for the older adults and at-risk children. Normally, insulin is released in the pancreas in response to a rise in blood glucose following the intake and digestion of food. In type 1 diabetes, pancreatic beta cells that produce insulin are destroyed by an autoimmune disorder, creating an absolute insulin deficiency where there is no insulin being produced in the body. In type 2 diabetes, insulin is produced, but it is ineffective at controlling blood glucose because of insulin resistance in body tissues. The pancreas increases insulin production to overcome this resistance, causing an excess of blood insulin in these individuals. Hyperinsulinemia, or elevated blood insulin concentration over time can contribute to a host of problems such as hypertension, hypercholesterolemia, excessive blood clotting, atherosclerosis, and kidney stones, to name a few. The main goal in the management of diabetes is adequately controlling blood glucose levels. Normal resting blood glucose level is less than 100 milligrams per deciliter. Diabetes is typically diagnosed when fasting blood glucose is 126 milligrams per deciliter or greater on 2 or more occasions. Another important measurement of glucose control is the glycosylated hemoglobin, or hemoglobin A1C, or HbA1c measurement. Although blood glucose numbers describe the blood sugar at a single point in time in people with diabetes, a normal HbA1c value is somewhere between 3.5% and 5.5%. People with diabetes have higher HbA1c values because their bodies have consistently higher levels of blood glucose. A goal level for HbA1c for most people with diabetes is under 7%. Exercise, among other treatment strategies, can be used effectively to achieve this goal. Exercise training affects many subclinical health factors associated with diabetes and is critical for diabetes management. The main exercise programming goals for individuals with diabetes are: number 1, to improve insulin sensitivity and blood glucose control and decrease insulin requirements. Number 2, improve cardiorespiratory fitness. 3, improve blood lipid profiles. Number 4, reduce blood pressure. 5, improve muscular strength and endurance through enhancing skeletal muscle mass. 6, improve flexibility and joint range of motion. 7, reduce body weight, particularly reduce intra-abdominal fat. And number 8, assist with decreasing the risk of diabetic complications. Consistency in a daily routine is the major pillar in diabetes care. This regularity refers to when meals are eaten, the amount and type of food, when medications are taken, and frequency, intensity, and time, or duration and time of day of physical activity. Fitness professionals, when working with clients with diabetes, should maintain regular contact with the client's physician or other healthcare provider when designing or making changes to the exercise program. This will enable a more consistent and appropriate treatment for the plan for the client. The majority of research regarding exercise training and diabetes has been done in the area of aerobic exercise. A hallmark training adaptation to be expected from increasing levels of aerobic activity is improved cardiorespiratory fitness. This positive outcome in particular carries tremendous benefit for clients with prediabetes or diabetes. Individuals with higher levels of cardiorespiratory fitness are at decreased risk of mortality from CVD compared with their counterparts with lower cardiorespiratory fitness levels, regardless of body mass index status, whether they're normal, overweight, or obese. These positive effects of aerobic exercise on glucose metabolism and insulin sensitivity in clients with diabetes are known to be subacute changes, meaning that they are lost within a few days following the cessation of training. For personal trainers, this provides support for a consistent, almost daily training regimen for clients with diabetes. If these clients are to achieve the full benefits of aerobic exercise, the program must involve frequent exercise activities with adherence on a daily basis. Regular exercise in clients with diabetes assists in controlling blood glucose, enhancing insulin sensitivity, decreasing and managing body weight and blood pressure, and improving lipid profiles, increasing cardiorespiratory fitness and exercise capacity, and managing some related conditions such as coronary heart disease and peripheral vascular disease. So frequency should be about 3 to 7 days per week with no more than 2 consecutive days between sessions, and consider progressing to 5 days per week. The intensity should be about 40 to 59% of the O2R or their heart rate reserve. If clients are overweight, sedentary, or deconditioned, start at the lower end. Time should be about 20 to 60 minutes, accumulating 150 minutes per week, with greater benefits and with more minutes. And type should be walking or a combination of weight-bearing or non-weight-bearing activities, aerobic activities, needless to say. And really the idea is to progress to maximize caloric expenditure. ACSM resistance training recommendations for healthy individuals in Chapter 4 are applicable for people with either prediabetes or type 1 or 2 type 2 diabetes. with the understanding that unique contraindications to resistance exercise exist in this population, including retinopathy and neuropathy, and following recent treatments using laser surgery. A resistance training program is essential for clients with diabetes to assist in managing their disease and associated complications, as well as maintaining their physiological function through improving strength and endurance. Some believe that the increased risk of diabetes with increasing age is partly due to a loss of muscle mass. This age-related muscle atrophy negatively impacts the ability to remain recreationally active, perform our activities of daily living, and maintain independence. Significant research has demonstrated the effectiveness of circuit weight training for managing and preventing diabetes. Clients would be well advised to perform circuit weight training regularly to regulate blood glucose and prevent age-related muscle atrophy. In fact, for individuals with diabetic complications such as retinopathy, circuit training with fairly light workloads is recommended, as blood pressure will not increase or spike as much as it does with higher loads. In summary, using resistance training to maintain skeletal muscle mass is known to be critical for managing and improving glycemic control and insulin sensitivity, decreasing HbA1c levels, reducing intra-abdominal fat, and improving the overall metabolic profile and quality of life in those with diabetes. When creating individualized training programs for persons with diabetes, there are other health concerns that are often accompany diabetes that need to be considered. Clients with diabetes should check their blood glucose before exercise. Ideally, blood sugar levels need to be between 100 and 250 milligrams per deciliter. If they are lower than this, the client should eat a carbohydrate-rich snack. Clients with glucose levels above 250 to 300 milligrams per deciliter will need to check urine for ketones, and if present, exercise should be delayed. If no ketones are present, exercise is okay, but use caution. Exercise has an insulin-like effect on circulating blood glucose, even in the absence of blood insulin. Thus, hypoglycemia, low blood glucose levels, is one of the most common but potentially serious complications that can occur during or after exercise in individuals with diabetes. The following strategies may be helpful for minimizing a client's risk of developing hypoglycemia. Know the warning signs of hypoglycemia and hyperglycemia. And we'll talk about those in Table 2011 here in just a moment. Avoid exercise during the time when hypoglycemic medication is working at its peak. Clients should eat 1 to 2 hours before exercise, perhaps eat a snack during exercise if duration is prolonged. Check blood glucose before exercise, and if blood glucose is less than 100 milligrams per deciliter, then the client should eat a snack. Clients should exercise with a partner for safety reasons, and always have fruit juice or candy available if blood glucose gets too low. Clients with diabetes are to work with their physician and or registered dietitian for nutritional recommendations related to controlling blood glucose with exercise. Clients need to be cautioned against late night exercise, as this could cause low blood glucose during sleep or nocturnal hypoglycemia and inadvertently cause a potentially life-threatening situation. Thus, if late night exercise cannot be avoided, the client should eat following exercise according to their physician's or registered dietitian's guidelines. Fitness professionals who work with clients with diabetes should be knowledgeable of and able to educate clients about the warning signs of hypoglycemia. Again, Table 2011 includes a list of selected signs and symptoms of hyper and hypoglycemia. Clients need to be taught the exercise guidelines that are specific for proper management of diabetes. For example, warm up and cool down, 5 to 10 minutes each, are particularly important in this population to avoid exercise-induced cardiovascular complications. Proper footwear is also critical for clients with diabetes, especially for those with or at risk for peripheral neuropathy and peripheral vascular disease. Clients need to be advised to maintain adequate hydration and avoid exercise in hot and humid environments, which will allow them to tolerate exercise better. and will assist in proper blood pressure and body temperature regulation. Also remember to recommend lighter resistance training workloads to avoid high blood pressure spikes, especially in those with retinopathy. In summary, the main programmatic considerations for fitness professionals who work with clients with diabetes involve minimizing the risks involved with exercising while maximizing benefits. In cases where the individual has complications of diabetes, such as diabetic retinopathy, peripheral neuropathy, and nephropathy, consult the client's physician before beginning the exercise program. These clients may need referral to a medically supervised environment if the conditions limit overall exercise tolerance or if they have signs and or symptoms of CVD. Obesity is currently defined as having a BMI greater than 30 kilograms per meter. Looking back over the previous 20 years, this has been a substantial rise in the number of people who are obese. According to the National Health and Nutrition Examination Survey, more than 1/3 of U.S. adults and 17% of youth in 2011 and 2014 were considered obese. Compared to males, females had the highest prevalence, and among ethnic groups, non-Hispanic Black females were higher compared to Hispanic females. The most recent data indicate that the increases are not continuing at the same rate, but the overall prevalence of obesity remains high. Reasons for the rising obesity levels are very complex and result from a number of factors, including increased caloric consumption or overconsumption, decreased levels of physical activity, genetic predisposition, disease, and cultural, environmental, such as homeschool, work, and community influences. The close association of obesity with physical inactivity, as well as to numerous chronic health issues, such as type 2 diabetes mellitus, CVD, hypertension, and certain types of cancers, tend to obscure understanding its cause and may complicate treatment. Although obesity is linked to an increased risk of disability and all-cause mortality, it is not clear if this is a causal association or a result of inactivity. Personal trainers who work with obese clientele should be prepared to interact and consult with a variety of professionals to design appropriate and effective exercise programming strategies. Personal trainers can make their greatest impact with obese clients by providing sound exercise programs that focus on promoting adherence to an active lifestyle that matches closely with appropriate dietary strategies. This is a challenge because it is common for overweight or obese individuals to have mainly deeply rooted negative attitudes and barriers to physical activity behavior that must be addressed before they can truly adhere to a program. The common exercise program goals for obese individuals are to, number 1, maximize caloric expenditure. Number 2, maintain or increase lean body mass to maintain resting metabolic rate. Number 3, improve metabolic profile. And 4, lower the risk of comorbidities such as hypertension, diabetes, orthopedic problems. 5, lower mortality risk. And 6, promote appetite control. And 7, improve mood state. The most recent ACSM position stand recommends a minimum of 150 minutes per week of moderate intensity physical activity for overweight and obese adults to improve health and to improve significant weight gain. However, greater weight loss and enhanced prevention of weight regain will likely need much greater doses, approximately 250 to 300 minutes per week or approximately 2,000 kcals per week of moderate intensity physical activity. Importantly, most evidence indicates that exercise alone without dietary restriction is fairly ineffective for weight loss, with an average of less than a 3% decrease. Extreme exercise or physical activity that results in a large negative energy balance will clearly result in weight loss. For example, it is well known that the intense energy demands of military training or mountain climbing will result in substantial weight loss without restricting caloric intake. However, It is difficult for most individuals to achieve and sustain these high levels of physical activity. Therefore, most individuals who require substantial weight loss may need additional interventions, such as energy restriction, to meet their weight loss goals. In terms of successful weight loss, diet with caloric restriction is the most important predictor. However, regular aerobic exercise should be used in concert with a low-calorie, low-fat, and high-fiber diet plan, therefore helping provide a negative caloric balance to achieve weight loss through maximizing energy expenditure, as long as the dietary restriction is not severe, greater than 500 to 700 kcals. Adding physical activity to the diet has been shown to result in greater weight loss compared with diet alone. Most importantly, once weight loss has occurred, regular physical activity in the form of exercise is the most significant predictor of long-term weight management. With nearly half, or 46% of the adult population with hypertension, it remains the most prevalent risk factor for CVD in the United States. Hypertension is the major contributor to the risk of stroke and is also related to the development of CAD, leading to myocardial infarction, heart failure, kidney disease, peripheral vascular disease, and blindness. Hypertension is often called the silent killer because of the lack of noticeable signs or symptoms of the disease until the development of serious problems. The updated definition of hypertension is an elevated resting systolic blood pressure of greater than 130 millimeters of mercury and diastolic blood pressure of greater than 80 millimoles of mercury. However, definitions now recognize elevated blood pressure, which is systolic blood pressure between 120 and 129 millimoles of mercury with diastolic less than 80 millimoles of mercury, as an equally important diagnosis. This lower blood pressure value indicates the need for early management of moderately elevated levels of blood pressure to help prevent hypertension. So some general programming goals in the management of hypertension are to, number one, lower systolic and diastolic blood pressures at rest and during exercise. Lower the risk of mortality from CVD, such as myocardial infarction, stroke, and heart failure. Number three, lower the risk of other comorbidities of kidney disease, eye problems, and diabetes. Number four, incorporate opportunities for clients to pursue other lifestyle changes such as stress management, diet, smoking cessation, and weight management. Aerobic exercise is the cornerstone activity in the total program for clients with hypertension. On average, clients may experience a decline of approximately 3 to 4 millimoles of mercury for systolic blood pressure and approximately 2 to 3 millimoles of mercury for diastolic blood pressure from aerobic exercise training. Greater change may be like 1 millimeter of mercury or more seen in those with diagnosed hypertension. Taken alone, these changes may not seem significant. However, when coupled with other treatment strategies such as diet and medication, the effect will be much more appreciable. Several studies have shown that higher cardiorespiratory fitness provides a cardioprotective effect of lower mortality risk from all causes and CVD in individuals with hypertension. Thus, improving overall fitness in clients with hypertension may be a worthy goal to pursue. Independent of the direct effects exercise may have on lowering blood pressure. The report of the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, or JNC7, indicated that in people with blood pressure of greater than 115/75 millimoles of mercury, CVD risk doubles for each increment of 20/10 millimoles of mercury. Fitness professionals can make a positive impact on their clients who have hypertension or pre-hypertension through appropriate exercise programming as part of a comprehensive lifestyle management strategy. Diet, stress reduction, smoking cessation, lower alcohol consumption, or medication regimen. ACSM recommends exercise for clients with hypertension on most, if not all, days of the week. Fitness professionals should encourage their clients to participate in daily regular exercise, as the subacute response of blood pressure following a bout of aerobic exercise is to remain below levels measured prior to exercise. This translates into more controlled and consistent blood pressure levels from day to day, which is ideal for clients with hypertension. In the review of past research studies, Welton and colleagues found a greater decrease in blood pressure with increased frequency of exercise of greater than 150 minutes per week. ACSM recommends moderate intensity exercise of 40 to 59% of O2R or heart rate reserve as the primary intensity prescription for individuals with hypertension. Fitness professionals should apply the lower end of this range for hypertensive clients who are deconditioned, older, or have comorbid conditions that can affect their risk of experiencing cardiovascular complications during exercise, such as diabetes and CAD. RPE can be used to help determine intensity rather than heart rate in the presence of certain medications that can affect the client's heart rate response during exercise, such as beta blockers, which are the main culprit. An RPE range of 12 to 13 on a 60 to 20 scale is appropriate for these clients to achieve moderate intensity exercise. ACSM recommends an exercise time of 30 to 60 minutes of continuous or accumulated exercise per session. Exercise duration goals are to be based on individual goals and personal history. A caloric expenditure goal of 2,000 calories per week is indicated to help treat persons with hypertension, especially if weight loss is also a goal. Clients with hypertension should primarily engage in aerobic endurance activities that involve large muscle groups and are rhythmic in nature. Avoid activities that emphasize isometric muscle contraction or that may elicit large blood pressure responses in your clients. The basic principle of progression generally applies to those with hypertension. Specific consideration should be given to blood pressure control. Recent changes in blood pressure medications and other comorbidities may be present. Progression must be gradual and avoid large increases in any of the fit components, especially intensity for most people with hypertension. Resistance training is considered a supplement to aerobic exercise and should not be prescribed as the primary form of activity for clients with hypertension. When supplementing with resistance training, intensity should be kept at 60 to 80% of 1 RM. Although studies have demonstrated a favorable blood pressure response to resistance training, the overall effect is not as great as the response to aerobic exercise training. Specific resistance training recommendations for these clients are similar to those used for apparently healthy adults. And teaching clients proper exercise technique, proper breathing, and avoiding large amounts of isometric work during resistance training will also help minimize large increases in blood pressure. The primary focus of these considerations is safety during and after exercise. As stated previously, hypertension is often associated with a variety of conditions that may require special attention and specific precautions during exercise. In these cases, the general exercise prescription may need to be modified to address these issues. In the past century, life expectancy in the United States increased from less than 50 years to greater than 76 years. The United States Census Bureau has projected by 2030 the number of adults 65 years of age and older will be approximately 70 million. However, current trends also show that although Americans are living longer, the number of individuals with chronic diseases continues to increase. Approximately 80% of individuals 65 years or older are living with at least one chronic health problem, and another 50% are living with 2 chronic conditions. Moreover, the presence of chronic conditions is linked with an even greater propensity of comorbidities. For instance, almost all individuals with diabetes have at least one other chronic condition, and nearly half have 3 or more comorbidities. These facts make it increasingly likely that the fitness professional will be interacting with clientele that have multiple chronic conditions. General programming goals in the management of clients with comorbidities are to, number 1, lower the overall risk of mortality by identifying the condition with the highest mortality risk. Prioritize exercise program design around this condition. Recognize that the presence of comorbidities may serve as a competing demand on client self-management resources, thus reducing time and energy an individual has remaining to devote to each and every condition. These individuals will require additional guidance and resources provided by the personal trainer to ensure that all conditions are managed effectively. Have realistic expectations for the expected improvement for all comorbidities. Improvement is not always feasible, and there will be instances where maintaining functional capacity or stabilizing the disease process can and should be viewed as a successful outcome. In general, the exercise prescription for individuals with comorbidities can follow the FIT-VP framework. Table 2013 provides a summary of the basic evidence-based guidelines for common clinical populations. This resource can assist with establishing the basic parameters of the exercise prescription around the various conditions of an individual. For example, consider an individual who has arthritis, dyslipidemia, hypertension, and type 2 diabetes. One strategy to employ when designing the program is to follow the specific exercise prescription for the chronic condition that poses the greatest risk of mortality for the individual. In this instance, type 2 diabetes is generally considered to increase the risk for heart disease and all-cause mortality more so than the other conditions. Other chronic conditions and specific limiting symptoms must also be carefully considered when formulating the program. In this instance, the frequency and time parameters of the exercise prescription for each condition are comparable. Yet there are some marked differences in the exercise intensity and recommendations between conditions. Therefore, it is prudent for the exercise professional to adopt the appropriate exercise prescription for the most restrictive condition. The greatest challenge for fitness professionals in designing exercise programs for clients with comorbidities is the amount of planning required. Considerable preparation is involved in designing programs to be safe during and after exercise and effective. The complexity of working with clients possessing multiple chronic conditions requires a thorough pre-participation screening. Baseline assessment and screening will help identify central problems that can prove useful in designing the exercise program and recognizing limitations. For example, insulin resistance is likely to be associated with obesity, hypertension, dyslipidemia, and other metabolic disorders. Likewise, a client with type 2 diabetes may be expected to suffer from complications of neuropathy, retinopathy, and or other microvascular complications. Including individuals with multiple comorbidities may also possess conditions of low back pain, lupus, osteoarthritis, fibromyalgia that fluctuate significantly within or between days in terms of severity. For example, sometimes pain levels flare in the early morning. Other times they increase just before bed. Fitness professionals must be prepared to accommodate an ever-changing chronic condition landscape with these types of clients and constantly adjust the session to best serve the client on any given day. Although experienced personal trainers can work with clients with stable chronic disease who are able to exercise independently, it is important to recognize situations when consultation with medical personnel is necessary or when the personal trainer should not undertake a client, such as inappropriate changes of resting or exercise heart rate or blood pressure, new onset discomfort in the chest, neck, shoulder, or arm, changes in pattern of discomfort during rest or exercise, shortness of breath at rest or with light exertion, fainting or dizzy spells, and claudication. Fitness professionals need to know the limits of their expertise and consider additional training and certification to work in concert with medical personnel in helping clients with multiple serious or unstable comorbidities. In conclusion, this chapter explored the special consideration of exercise program design for children, older adults, those with cardiac disease, pregnancy, diabetes mellitus, obesity or hypertension, and individuals with comorbidities. Personal trainers are ultimately responsible for designing the safe and effective programs that make a positive difference in the lives of their clients. Fitness professionals are encouraged to use evidence-based practice to design to guide their selection and use of a specific intervention in a given situation. Evidence-based practice is the integration of best research evidence with professional expertise and client values. The rationale for basing decisions on sound evidence is clear. Programs supported by research lead to an informed action plan that minimizes risks and optimizes effectiveness. And that concludes our discussion in Chapter 20 of our special populations. Thank you. I look forward to talking to you soon. Have a great day.